Welcome to another e-class by the Wincars Association. And this time we have an interesting case, and this is from Amrita Heart Institute. And we have examiners Dr. Hitan Shah and Dr. Jyotsna, who will be examining Dr. Amrita from Jaydeva Institute, and Dr. Usha Shastri will be discussing the case. So over to you, Amrita. You can start the case. Usha ma'am, you can question her also. Okay?
Yeah, sure.
Yeah,
Thank you.
And I request all the listeners or the students to answer by typing in the chat box. Please, the questions are not only to the who are going presenting it, but it is to all the students. Thank you.
Good evening, ma'am.
Yeah,
Good
start,
evening.
Amrita.
Please start.
Good evening.
Sorry, I'm not able to. Yes, ma'am. So we had a 20-year-old unmarried female. She was a resident of Ballari, a farm laborer by occupation. She came with presenting complaints of low-grade fever since 1 year, weight loss since 1 year, recurrent left ear pain since 1 year, and a headache since 1 day. The patient was apparently all right 1 year back when she started developing intermittent low-grade fever, and she was advised ear surgery 1 month back. During her preoperative workup 1 month back, she was diagnosed with hypertension and started on 2 medications. She underwent further evaluation for hypertension, including blood investigations, ultrasound, and a CT scan. She presented to our emergency department 1 day back with complaints of a holocranial throbbing headache, which was associated with dizziness and was detected to have a high blood pressure. She was treated with injectable medication, following which her symptoms had resolved. In negative history, she had no history of dyspnea, chest pain, or palpitations, no history of edema, oliguria, hematuria, or abdominal pain, no history of muscle weakness, cramps, polyuria, or fatigue, no history of tremors, goiter, or heat intolerance, no history of upper or lower limb claudication, no history of vision loss, stroke, or a transient ischemic attack, no history of skin rashes, ulcers, or joint pain, and no history of COX or COX contact. There was no significant medical history in her past, and there was no history of hospitalization since childhood. She consumes a mixed diet with normal bladder and bowel habits, gets adequate sleep, and denies any addictions. She is the second child born of a non-consanguineous marriage with no significant family history. She's attained menarche at the age of 13 years with regular menstrual cycles. In summary, a 20-year-old female who presented with recurrent low-grade fever and weight loss since 1 year with a history of recurrent left ear infection for which she was advised surgery. She was diagnosed with hypertension during a routine preoperative assessment.
So, what is the information you are able to get from this history?
Yes, ma'am. So we have a young female, 20 years of age, who was diagnosed with hypertension young onset, and she's giving history of fever and weight loss, which constitutes as constitutional symptoms. So we are looking for differentials of hypertension occurring in the young age with constitutional symptoms. So our first consideration would be an aortoarteritis, possibly Takayasu's. We would also keep in our differentials connective tissue diseases, any other causes of renal parenchymal diseases, or neuroendocrine malignancies or tumors.
Another way of the thinking is that the patient has an ear pain with a discharge which requires a surgery.
Yes,
Can
ma'am.
that itself can explain the constitutional symptoms? And can you think of only the isolated hypertension?
Yes, ma'am, that is one possibility. However, she had associated her ear pain and discharge with episodes of high-grade fever, which had occurred only 2 times. One episode was 1 year back, and the second episode was 3 months back. And these symptoms had resolved with a course of oral medication. However, there is still the chance that a chronic low-grade suppurative or infective process in the middle ear might lead to weight loss and intermittent fever.
Okay. Other than these conditions, you said that aortoarteritis and the collagen vascular. Can you be specific, especially with these ear pains? And can you be more specific at the collagen vascular?
In this case, we can think of SLE causing a renal parenchymal hypertension, or we can think of medium vessel vasculitis, including polyarteritis nodosa. We may also think of Behçet's disease, causing again a renal parenchymal disease with hypertension. Mm.
Behçet's, does it cause a renal parenchymal issue?
More of an
Behçet's is more of ulcers and aneurysms.
yes, ma'am.
If you should think of vasculitis, obviously because of the incidence, SLE would be the first.
Yes, ma'am.
What other medium vasculitis can come with long-standing See, when was the hypertension detected?
It was detected 1 month back during her preoperative evaluation. She was
So
not
actually, constitutional symptoms have been long-standing.
yes, ma'am.
Hypertension is recent onset.
Ma'am, it was detected 1 month back, but there are no records.
Symptoms due to hypertension has been recent onset.
Yes, ma'am. Yes, ma'am.
Yeah.
The headache was there 1 day back when she presented with accelerated hypertension.
So I think rather than putting aortoarthritis as first diagnosis, in this patient with, usually it's very unusual to have constitutional symptoms lasting for such a long duration in aortoarthritis. Okay. They are transient and most often missed. If you have constitutional symptoms for a long time, you should think of other systemic connective tissue disorders like SLE or other medium vessel vasculitis. Like, can you name some?
Ma'am, polyarthritis nodosa.
Then?
Ma'am, Kawasaki's disease, but that will more often be in children.
Kawasaki, no, I don't think you should bring in Kawasaki. This is nowhere close to Kawasaki. Wegener's, Church-Strauss, okay.
More smaller
can,
also
yeah.
can. Yes, ma'am.
They can come with hypertension.
Constitutional symptoms are usually present intermittently. Like for them, disease may be associated with the disease in activity. So the continuous constitutional symptoms is not a feature. And a few of the other important things which you have to consider is rheumatoid arthritis and sarcoidosis in this type of the cases with who has a long-standing constitutional symptoms.
Yes, ma'am.
Yeah, someone is saying something. Yeah, I'm not seeing anything in the chat box. I wanted the other people's opinion when the questions are there asked. And I wanted something related to the ear or the head problem and with the hypertension. Can you think of any other conditions?
Vaginal granulomatosis.
Vaginous granulomatosis, okay. Anything else?
Related vasculitis.
Temporal arteritis?
Unlikely in this age, ma'am.
Younger female and
She's 20 years.
yes, ma'am.
Yeah. So it is not an unusual to have it. So the features of the headache, what are the features of the other than the constitutional symptoms you could highlight it?
Ma'am, her complaints mainly included a low-grade fever and a weight loss, which was there of 1 year duration. The symptoms of hypertension were only there during the episode of accelerated hypertension. She had presented with a throbbing headache, which was holocranial, which was associated with dizziness. Apart from that, she had mainly symptoms relating to her left ear infection.
Okay. So what are the causes of this throbbing type of the headache in the conditions what you are explaining it and the further dizziness?
Ma'am, first, her accelerated hypertension itself could have caused a throbbing kind of headache. The presence of giant cell arteritis, although unlikely at this age, may also cause a temporal headache.
What is the meaning of this dizziness? Usually the dizziness requires some clarification because the central or the peripheral, and some of the arteries involvements will have the more the dizziness. So what artery involvement and what history wanted to take?
Involvement of the vertebral arteries may be associated with dizziness. If you're considering a diagnosis of Takayasu aorta arteritis, involvement of the vertebral arteries might be a consideration in her case, or involvement of the carotid arteries with a decreased supply to the brain might also be considered.
Yeah, that is important. Vertebral artery involvement usually will predominantly will have the dizziness. So you have to able to distinguish between the vertigo and the dizziness when you are explaining it. So little bit of an elaboration on that symptom may be the more helpful to know the different arterial involvements. So do you consider any congenital, because you are considering only the all the neck-acquired conditions and everything at the age of the 20 years? Still, we know that some of you the congenital diseases can be manifesting it.
Yes, ma'am. A coarctation of aorta would also be on the differential. However, ma'am, because she presented with constitutional symptoms, it would be lower down, but it is definitely possible that she may present in adulthood with hypertension and have a coarctation of aorta that might have gone unnoticed during her childhood.
Anything else you want to consider? Any other congenital
As
condition?
that infective endocarditis query in the chat box.
Infective endocarditis, usually presentation is type of the fever is not very much suggestive. Low grade fever for such a long time or the 1 year duration is unlikely. And there is a correlation between the ear discharge and the high grade fever. So
Yes.
we have another explanation to give to that.
So which
Okay.
connective tissue disorder would come with headache?
Ma'am, temporal arteritis might be associated with a temporal headache.
Yeah, then, but that is a little lower down on the list because of the age of the patient.
Yes, ma'am.
Okay.
Because of the age. Yes, ma'am.
So if you consider other connective tissue disorders, what would be the reason for headache? CNS vasculitis in SLE. Okay. PAN will not cause. CNS vasculitis in SLE can lead to severe headache. If you or other could be a severe hypertension due to any of the either PAN or Wegener's or SLE leading to headache. Okay.
Yeah, there is a fibromuscular dysplasia is also mentioned, but that is more frequently with aneurysms. But yes, it is known to have this type of the presentation. It's not unusual, especially with the renal artery involvement with the aneurysms.
Renovascular.
We can have the accelerated hypertension. I can't understand what is NSAA. Or probably they meant what is that? I don't know yet.
Specific aortoarteritis, ma'am.
Sorry.
Non-specific.
Non-specific aortoarteritis. Okay. Sometimes it becomes very difficult to elaborate on these shortcuts. Okay.
So non-specific aortoarteritis is non-specific. So there's no entity as such described. If you take large vessel vasculitis, there are only two entities. So Takayasu arteritis and giant cell arteritis. Okay, there are no other types of vasculitis described. So there is no description of non-specific aortoarteritis in literature because as such Takayasu itself is non-specific. There is no diagnostic histopathology to say Takayasu arteritis. So any abnormality of the aortic wall, if below 40 years, you would consider as Takayasu arteritis. That's why there are so many criteria which have come up in the last few years to make a diagnosis of Takayasu arteritis. Okay, shall we go ahead, ma'am, with examination?
Sure.
On general.
One more thing I want to consider is any endocrine causes you wanted to consider or no?
Yes, ma'am. We can consider her primary hyperaldosteronism, or we can also consider hyperthyroidism, given that she has a history of weight loss and fevers. So these two would be prominent.
Yeah.
We may also consider the presence of neuroendocrine tumors. We may consider a pheochromocytoma. However, the typical episodic palpitations or headaches were not seen in her case, but that would still be in the differential, ma'am.
Yeah, sure. Yeah, even there also is mentioned about the pheochromocytoma. Yeah, please go ahead.
Can tuberculosis present like this?
Ma'am, renal vessel involvement in tuberculosis may present either because of vasculitis or because of tubular interstitial nephritis or parenchymal damage. Tuberculosis may definitely cause fever and low grade and weight loss, and the hypertension may be associated with a renal parenchymal involvement. So tuberculosis may present.
Because she has persistent constitutional symptoms. She has significant weight loss. I think you should not rule out tuberculosis as one of the DDs.
All said and done, even Takayasu, they considered that tubercular protein is responsible, antigen is responsible.
Yeah, it's antigenic response to tubercular protein.
Okay, general examination.
The patient is conscious, cooperative, well oriented to time, place, and person. She has a height of 155 centimeters, a weight of 42 kg, and a BMI of 17.48 kilogram per meter square. She is afebrile at the time of examination. Her pulse rate was 86 beats per minute with a regular rhythm. Pulse over the right carotid artery was well felt, while it was absent over the left carotid artery. The pulse was bounding over bilateral brachial arteries and bilateral radial arteries. The pulse was feeble over bilateral femoral, popliteal, posterior tibial, and dorsalis pedis arteries. There was no radioradial delay. However, radiofemoral delay was present, and there was no evidence of carotidynia.
Yeah, I think in this case, pulse is the most important one. So I think we can have a slight discussion on this. Why you wanted to say no radiofemoral delay? What is the normal arterial transmission to the peripheral sites?
Ma'am, it will take 20 milliseconds, around 80 milliseconds to reach the radial.
20 to what?
20 milliseconds difference between the radial and the femoral pulse, ma'am.
Okay, some people will say 15, that is 60 and 75. Okay. No, tell the absolute numbers and what is the differences. Why you want to take it, when you can perceive the difference, why you wanted that difference.
Ma'am, more than a 30 millisecond difference we will be able to perceive. Usually the pulse will reach the brachial artery by 30 milliseconds, radial by 60, and the femoral by around 80 milliseconds. Ma'am, so any prolongation, rather a slow peaking of the pulse wave is what presents as a radiofemoral delay rather than a delayed arrival of the pulse wave.
So the 30 milli normally, can you make the difference between the radial and femoral, or you can't make any difference?
No, ma'am, normally we cannot make out the difference.
And actually carotid is considered as a 30 and brachial as a 40. But anyway, probably one book maybe they're saying that differently. But this is an arterial pulse tracing says that is a 30 is the carotid and 40 is the brachial and 60 is the radial. So the radiofemoral is an important because it is normal is 15, which is not perceived. Once it becomes in a perceived means there is a definite difference is there. So that's why you are saying the radiofemoral. Any other delays is an important to know about it?
Ma'am, a brachiofemoral delay may also be noted.
It becomes much more easier. Means more gap will be there. So, but to quantify the disease process, probably more proximal vessel consideration is not there. And what is this carotidynia?
Ma'am, pain or tenderness over the carotid arteries is carotidynia. She did not give an
Specific with the carotid, why it has to be mentioned only there?
And because it is commonly associated with aortoarthritis, and it is seen in almost 70% of patients of Takayasu's arthritis, as per Dr. George Joseph series. But however, she has not complained of any neck pain, and there was no tenderness on palpation of the carotid arteries.
No, what I meant to say is most of these peripheral arteries are the palpable at every area. Why the pain is present only in the carotid? Isn't that is so isolated the inflammation occurs to the carotid? Is there any explanation why the carotidynia is more frequent?
I have not come across an explanation per se.
It is easily palpable, no, Amrita?
Is
You cannot palpate a subclavian artery.
mm,
Right? This is just underneath. Inflammation will be there in all the arteries, but you cannot palpate the other branches. So vascular pain is described, but very rarely people present during the period of acute inflammation. So carotidynia, though, is supposed to be very specific in the criteria for diagnosis of aortoarthritis. Does it come as a major or minor criteria?
Ma'am, it comes as a minor criteria. The carotid
Yeah.
artery, it will come as a minor.
Correct.
Major criteria only involve the subclavian artery involvements.
Yeah. Only thing why it is minor is because it is unusual. Okay. But if you have carotidynia, then the diagnosis is straightforward that it is a large vessel vasculitis.
That is a major thing. The carotid large vessel which you are not able to feel is the carotid. Whereas the subclavian involvement is the produces the brachial and the radial pulse absence. It is not the inflammation at that site to have that. That's the reason why you are not having the pain in that. It is proximal occlusion which is responsible for the pulse loss.
Yes, ma'am.
Whereas in the carotid is direct inflammation of the vessel which is responsible for that and which you can palpate very well. That's the reason that is much more frequently than known. And any other arteries you wanted to palpate it, because few of the diseases we thought of.
My bilateral femoral arteries, we've palpated, they were feeble.
Other than the arteries what you mentioned, would you like to mention any other pulses?
Ma'am, subclavian artery, we may, like if it is prominent, we may feel, or
Where
You
you will feel the
cannot feel
subclavian?
subclavian.
Where
No.
you can feel the subclavian?
if there's a thrill over the supraclavicular region, we may feel it, but typically we do not
There
palpate
is one area where you can feel the subclavian, but it should be a thin individual. Where is that area?
I'm in the supraclavicular fossa, ma'am.
Okay, very rarely. It is usually beyond the second rib. So even the supraclavicular fossa, unless the aneurysm or the abnormality is there, you can't. It is the axilla, pit of the axilla. In a child, you can feel the beginning of the subclavian artery.
Yeah,
So that is
where
not a
it
common feature.
converts into axillary artery. Okay, only that point. Otherwise, if you want to take a subclavian axis, you always go beneath the clavicle, no? So you cannot feel it in the supraclavicular area.
And you talked about the temporal arteritis. Don't you want to see for the temporal arteries?
Yes, ma'am. The temporal arteries were well felt, and there was no pain or tenderness over the temporal arteries.
Yeah, that is also worth mentioning because of the it's differentiates between the other conditions. And some people will say that in abdominal examination you can say, but it's predominantly the pulse examination. So you can tell about the abdominal aorta palpation. And if some areas you can palpate the abdominal aorta very well.
Yes, ma'am. In the epigastric region, we may palpate the abdominal aorta, especially in thin individuals. In her case, ma'am, we actually did feel a pulsation in the epigastric region. I've mentioned it.
Yeah, that's what. Either you can say in the abdominal separate examination or in the pulse, because basically the pulse disease, that's why. Yeah, please go ahead.
Her blood pressure over the right upper limb
And
was
the pulse description, I think volume and everything you can quantify, grade it, na?
yeah.
So how do you grade it?
It will be a low volume, normal, or high volume. Ma'am, in her case, actually, it was a high volume pulse over the upper limbs, and over the lower limbs, the pulse was low volume or feeble.
So is there any grade like a 0 to 4, or you wanted to say only high, low, and
Mainly, we'll quantify as either low volume, normal, or high volume, ma'am.
but there is a classification to say that actually 3 is the normal, whereas 4 is the bounding, and 1 is 0 is complete absence. 1 is just palpable but still, and 2 is also the similar way. It is more palpable but still less than the normal. So this grade is important, especially to say that what is the severity of the disease.
So it would be almost 2 over the lower limb muscles.
What do you think that is the reason for bounding? You mean to say that it is more than normal, huh?
Yes, ma'am.
Yeah. So what do you think that what is the reason for the bounding nature?
And possibly because of the hypertension, the pulse was very well felt.
Hypertension produces bounding.
Actually, aortic regurgitation was also a possibility, in which case we may get a collapsing pulse, but a typical collapsing pulse was not noted in her case, ma'am.
So hypertension doesn't produces the bounding pulse. It's a prominent pulse. So the bounding nature usually suggests that there is some leak is occurring, like any peripheral runoff. Need not to be the only this. But if it is absent in other arteries and present only in the upper limb, then we have to consider different diseases. Okay, go ahead. The dorsalis pedis absence, do you give importance?
Ma'am, involvement of the distal vessels, any obstruction or occlusion proximal to the dorsalis pedis would give rise to an absent dorsalis pedis.
As a normal variant is known to occur?
Ma'am, any anatomical variant might have an absent dorsalis pedis.
In 2% of the cases, you don't feel the dorsalis pedis at all. So, if you have a proximal feebleness, this gains in more importance. Just absence of the dorsalis pedis may not be, but posterior tibial, yes. And you are not mentioned about posterior tibial, I think.
Yes, ma'am, I've mentioned.
You mentioned. Okay, good. Go ahead.
Blood pressure over the right upper limb was 190 over 110 millimeters of mercury. Over the left upper limb, it was 194 over 110 millimeters of mercury. Over the right lower limb, the pressures were 110 over 70 millimeters of mercury. and over the left lower limb, 104/60 millimeters of mercury.
So what is the information you are getting from this blood pressure?
Ma'am, the blood pressure over both the upper extremities is equal. Ma'am, so the chances of a
First, you start with the description of 190 by 110. What that says it?
Ma'am, there is a wide pulse pressure, and there is also a pulse pressure difference between the upper extremities and the lower extremities. So this will point towards an abdominal aortic narrowing, which is giving rise to this
You
gradient.
say that it's both systolic, diastolic hypertension with a pulse pressure of. Your description of the BP should be, if that is there, then you don't miss anything.
Yes, ma'am. She has a high pulse pressure of almost 80 millimeters of mercury. So in her case, and there's also a difference between the systolic blood pressure of 190 over the upper limbs and 110 over the upper limbs, which gives us a gradient of 80 millimeters of mercury. This can point towards a abdominal aortic narrowing, which would be severe.
Why are you jumping to the conclusion of abdominal aortic narrowing?
Ma'am, descending aortic narrowing, either descending thoracic or abdominal aortic narrowing.
Yeah,
ma'am.
it can be in either of the locations. So why
And-
not coarctation?
Ma'am,
What
coarctation,
other sign would you look for if you are thinking of coarctation as a possibility?
ma'am, in her history, we would expect a history of,
No, signs.
ma'am, we might expect collaterals in case of coarctation of aorta.
Hmm. So how do you, clinically, can you pick collaterals?
Ma'am, Sussman's sign we can expect over the back.
Did you do?
No, ma'am, in her case, like specifically, I did not look for Sussman's sign, ma'am.
See, the constitutional symptoms might be due to something else. You cannot be very sure that it is not coarctation. You should have looked for Sussman sign in this patient. Does collaterals exist in aortoarthritis?
Yes, ma'am. Collaterals may develop in aortoarthritis as well. And when slow pathway collaterals have been described in aortoarthritis, joining the internal thoracic artery and the internal mammary artery to the external iliac artery. So this may aid in the blood supply of the lower limbs, ma'am.
Yeah. Earlier, they thought that collaterals don't occur because the entire aortic wall is fibrosed and scarred. But long-standing aortoarthritis, collaterals do occur. But the amount of collaterals you get in aortoarthritis can never be as dense as what you get in a congenital coarctation of aorta. Okay. So for a 20-year-old to have coarctation of aorta with not much symptoms, she should have a well-developed collateral system. So you should have looked for that collateral and it must have been present. Okay.
And another thing I wanted to add to that is aortoarthritis is an osteal disease involvement. So, like all arteries are known to have an osteal involvement, even the collaterals also is known to have an osteal involvement. That's the reason, even though the collaterals are the present, you are not able to hear them so frequently the flows through the collaterals. But all said and done, the gradient is. Do you say that this gradient of 80 is reliable in this case?
Ma'am, she may have a multiple level of occlusion or she may have a diffuse aortic disease. So what we get is largely the gradient between the aorta, which is at the descending thoracic aorta, and the lowermost parts.
Yeah, actually, just to know the gradient, you can say the severity, but the major thing is this may not be the real gradient. Like in the presence of the collaterals, as you said that it is known to then increase the blood circulation. So you may have the decreased gradient, but once it is crosses the 60, that itself say that it is severe. Whether what is the level at multiple levels or single level or not. So you can take at least in this case as a severe descending thoracic obstruction. And 110 of the lower limb of right side and 104 of the left, do you consider that is a significant difference in systolic pressure?
No, ma'am, we need at least a pressure gradient of 10 between the two limbs to call it significant. But however, we cannot rule out that iliac artery involvement may still be present. It may be bilateral or unilateral. Just based on the pressure differences, we cannot rule in or rule it out.
Yeah, actually Hudson mentions about 12 to 13 millimeters between the two limbs is considered as a normal. Some people will say as 10, but it's okay. Yeah. Please go ahead.
Amrita, what did you say? How much pressure difference is significant?
10 millimeters.
You are saying 10 millimeters is significant.
Yes, ma'am.
But overall, what is the gradient in which you would like to intervene?
So more than 20 millimeters of mercury would be significant, and then we can grade it as mild, moderate, or severe based on where it is between 20 to 40, 40 to 60, or more than 60. In her case, the gradient across the descending aorta is
What
definitely.
you are saying, 20 is for the aorta.
Yes,
What
ma'am.
we are talking is about the left upper limb to the right upper limb. So that
Okay.
is 13 is sufficient enough. Not for intervention. It is to say that it is a significant disease.
Pathological, yeah, yeah. Okay, significant gradient is 20 between upper limb and lower limb, whether you get it on cath or you get it clinically. Actually, clinical gradient always matches with cath gradients. And like ma'am said, 13 up to 13 mmHg might be an acceptable difference between the both upper limbs.
Yeah, please go ahead.
The jugular venous pressure was not raised with a normal abdominal jugular reflux. Respiratory rate was 14 per minute, thoraco-abdominal. There was no evidence of pallor, icterus, clubbing, cyanosis, or edema.
In a jugular venous pulse, make a habit to say that waves what you are saying and go systematically. Even though there is no abnormality, better to say it.
Yes, ma'am. Uh,
And especially, do you expect any abnormality in this with the findings what you have it?
no, ma'am.
Okay.
Why you're not thinking of what are your DDs?
Ma'am, mainly descending aortic involvement with carotid artery involvement because the left carotid artery was not
No,
palpable.
coarctation and aortoarthritis were your
Coarctation.
main DD. So can that come with cardiac dysfunction?
Ma'am, left ventricular dysfunction may be seen. We may also have aortic regurgitation that we may expect.
Only
what
left ventricular dysfunction?
I'm sorry, ma'am.
Is it only left ventricular dysfunction?
Ma'am, if we have Bernheim effect, we may have some right ventricular pressures that may be increased, in which case we may see a prominent A and B waves, ma'am.
A wave, why V wave?
Mainly the A waves, ma'am.
Yeah. And why AR will have an effect on the jugular venous pulse?
AR will not put any LV dysfunction or dilatation of the left ventricle.
So
Maybe
basically, LV function can have an effect,
Yes,
not an AR. AR
AR
can't have an effect on the jugular. Yeah.
And myocarditis is a part of manifestation of aortoarthritis.
Yes,
Okay.
ma'am. Myocarditis itself may explain the LV dysfunction.
So your patient may not have had the symptoms, but you should always look for latent heart failure. It can be myocarditis. It can be it can be a response to severe hypertension also. Okay.
Yes, ma'am.
Only for completion sake, I'm asking. Any variety of aorta arthritis can have jugular venous effects? Have you heard about the pulmonary artery involvements?
When pulmonary artery involvement in aortoarthritis may cause right ventricular hypertrophy. It will increase the afterload to the RV. In that case,
Actually,
we have
the types of the classification, they said coronary artery involvement, pulmonary artery involvement as a type 4, type 5. So then it is known to be then associated with the PAH and you can have it. This is for the completion sake, not that we have seen a cases like that. Yeah, please go ahead.
She had systolic pulsations of the aortic type noted in the epigastric region. A systolic bruit with thrill was present over the right carotid artery. A systolic bruit was heard over the left paraspinal region over the back, and a systolic bruit was heard over the anterior abdominal wall over the abdominal aorta.
What is that bruit suggest? What is the exact meaning of the bruit?
And basically, it will indicate to an underlying turbulent blood flow because of a stenosis which is present, and it indicates a significant pressure gradient across the area.
Yeah, bruit need not to be a pressure gradient. It could be increased flow. That word is a better word. Usually associated with the stenosis, but you are known to have the bruit presence. If you in the renal failure patient, you create a fistula, you will have the significant bruit there. So it
Please-
doesn't mean that it's a stenosis.
No,
It
ma'am. In
is
that case,
increased flow across a one particular segment of the artery will produce that bruit.
yes, ma'am.
So how could you say it is an aortic type in epigastric area?
Ma'am, on palpation of the epigastric area, the The thumb was getting lifted upwards. The palpation was lifting the thumb directly upwards, and it was not from the tip of the thumb that we could feel the pulsation. Typically, if we have an RV pulsation, we will feel it at the tip of the thumb, but this pulsation was felt more on the pad of the thumb.
And the systolic bruit over the left paraspinal region, what that implies?
Over the descending thoracic aorta, basically there was the presence of a systolic bruit, ma'am.
So you mean to say that it should be paraspinal, it can't be on spine?
It was also present on the spine. This was slightly better heard in the paraspinal.
Actually, how is the abdominal aorta descends from the thorax to the abdomen?
The ascending aorta will lie on the right side. Then we'll have the arch, and then we have the descending thoracic and abdominal aorta, slightly towards the left side of the vertebral column.
So the whole of the descending thoracic is to the left side.
No, ma'am. Most of it will lie to the left side.
And its worth is mentioning on the spine also. Why it is important is like a spinal artery diseases is also known to then have the presentations like this. So to distinguish from those conditions, it is worth spending time to hear on the spine.
Yes, ma'am. It was auscultable both over the spine and over the left paraspinal region.
Okay, as the madam already mentioned, so Suzuban sign has to be mentioned. This negative findings has to be important to know to distinguish the things. Okay.
Did you look for any stigmata of other connective tissue diseases?
Ma'am, there was no evidence of any stigmata of any other connective tissue diseases, nor were there any peripheral signs of aortic regurgitation.
You should mention, okay.
Is there any
What are
dermatological
the
manifestations? Sorry.
what are the
please.
stigma of connective tissue disorders you can see clinically?
Mainly, we can look for rashes. In case of SLE, we may look for a malar rash. We can look for any joint pain, or we can look for ulcers in oral ulcers.
Do you have any dermatological manifestations in aortoarthritis? Is only the collagen vascular disease you get it?
Per se, we may have ulcers over the lower limbs if there is significant narrowing that can lead to a vascular gangrene.
That you mean to
Can
say
aortoarthritis, sorry, I interrupt you. Can aortoarthritis extend beyond the iliac vessels?
Less likely. It is more of a large vessel
Why?
vasculitis. But a few
Why?
more important,
Why?
ma'am, it
Why
is
disease
a
don't?
large.
And you are saying, Madam has asked you about the peripheral sides. You are saying lower limb, the gangrene and all. It's not there.
Yes, ma'am. Less
But
likely.
why the disease won't extend beyond the iliac vessels?
Typically it starts in the vasa vasorum over the adventitia. So that is why it is typically a large vessel vasculitis. It will start at the adventitiomedial junction from the vasa vasorum.
Iliac vessels are also reasonably good size vessels.
Yes, ma'am. Iliac vessels,
It's a medium size, no? Not large.
Yes, ma'am.
Why the disease don't extend beyond the iliac vessels?
Never mention gangrene
Yes, ma'am.
for aortoarthritis. Okay.
That it won't be
that is
there.
not a feature actually. That
Yeah,
is
it
one of
won't
the
be
features
there.
that distinguishes from the other diseases like the Berger's and everything. And
Yes.
you are telling the dermatological manifestations in aortoarthritis.
Somebody has answered,
Gangrene is gone.
needs adventitia. Vishwajit has answered.
Yeah, that's what she also said, the vasa vasorum of the involvement of the adventitia. Yeah, that is the mechanism why it is not involving the more peripheral arteries. So, erythema nodosum is known to then occur. Actually, we think that it is so specific for the particular diseases. Actually, with 6 to as high as 20%, the erythema nodosum is known to then occur. These ulcerated subcutaneous nodular lesions are seen in less than 2.5%, but it is not because of an arterial insufficiency. It is a dermatological manifestation of the inflammation. What is responsible for that? But it is so rare. So also the pyoderma gangrenosum. Just to say that yes, it is not only collagen vascular, even aorta arteritis can have these manifestations. Okay, go ahead.
In cardiovascular examination, on inspection and palpation, the chest wall is bilaterally symmetrical with no dilated veins, scars, or sinuses. Pericardium appears normal. Trachea is central. The apex is localized to the left fifth intercostal space in the midclavicular line and has a heaving character. There was no palpable sound or thrill noted over the pericardium. On percussion, the left heart border corresponds to the apex and the right heart border is retrosternal. On auscultation, the S1 is normal. S2 is normally split with a normal sounding P2 and loud A2. No audible S3 or S4 could be heard, and no audible murmur could be heard. On respiratory examination, bilateral vesicular breath sounds were noted with no added breath sounds. On the GI system, the abdomen was soft and non-tender, and no palpable organomegaly could be noted. On CNS examination, there were no focal neurologic deficits.
I expected that you will concentrate a little bit on the arterial system of the abdomen. Because you said the renovascular hypertension, renal involvement, but you have not talked about that at all.
I had mentioned that in the general examination itself, ma'am, there was a bruit which was heard over the abdominal aorta. Ma'am, this could actually not be differentiated from any sound over specifically over the renal arteries.
How do you auscultate for the renal artery bruit?
Ma'am, we will take it 2 centimeters above the level of the umbilicus and 2 centimeters lateral to the umbilicus, with the left slightly being low.
In the front or back?
In the front, ma'am.
In the front. Okay. It should be a calm room. That is the most important.
Yes.
The bruit, once one bruit is there, heard in some other area, to add, to see for the additional bruit. What you are describing is in the pure renal artery stenosis. Now the problem is the patient has some abdominal disease, abdominal aorta or thoracic aorta disease. In addition, you are talking about the renal arteries. So then it is to distinguish this should be then away from that of the center of the spine. It need not to be from the anterior wall of the abdomen. It could be in the posterior also.
Okay.
So that is one feature in the aorta artery specifically you have to see for that. What you are talking is a renal artery hypertension, isolated renal artery involvement. So the worth mentioning about that also. And of course, bruits are not heard in the other areas. That is also is important. That mean to say that what is that bruit says to you? Actually increased circulation and everything is okay. But if you think that is a stenosis, what that says?
My presence of a turbulent blood flow.
Yeah, that is accepted. I'm saying that it is because of stenosis. So
Yes.
what that implies to you?
And that there is a significant pressure gradient across the proximal and the distal part of the stenosis, which is like significant enough to cause a turbulence.
Can you type of the murmur what you heard or the bruit? Can you classify the severity of the arterial stenosis?
Ma'am, actually, if it is a total occlusion, in that case, we will not hear any bruit at all.
Yes.
If you're
Good.
hearing a bruit, it means that at least there is some amount of flow that is present across the stenotic segment.
So
And-
when it is going to be systolic, when it is going to be becomes a continuous going to the diastolic component, we talk about systolic and diastolic not only in the heart, even in the arterial system also we heard about it.
Yes, ma'am. Ma'am, if there is a continuous pressure gradient, both systolic and diastolic, in that case, we will hear a continuous bruit. But in this case, ma'am, we heard mainly a systolic bruit. So, ma'am, mainly a
Severity wise is that 50 to 70% of the arterial stenosis, usually the murmur or the so-called the bruit, we don't say the murmur and the artery. So bruit is confined to that of the systolic. Once it is crosses to the 75% of the stenosis, it spills over the diastolic component, then it becomes a continuous. And as the severity increases beyond the 95 to 100, you don't hear any murmur. So the duration of the bruit will give you what is the degree of the stenosis. Okay, please, your clinical diagnosis. We have 8:15, so 15 minutes for other discussions. Okay.
And did you mention the fundoscopy?
No, ma'am, I had not done. I would wanted to do the fundoscopy.
Yeah. So before you conclude your clinical diagnosis, you should have said that I had not performed fundoscopy, but I would like to.
Yes, ma'am.
Why it is important?
Ma'am, because we have typical changes that we can expect in a case. So she may have
What
hypertensive.
are the changes you are expecting?
Ma'am, so in Takayasu arthritis, we can expect a wreath-like anastomosis, which was classically described. Or we may also see it in different stages. In the 4 stages have been described for Takayasu's retinal changes.
So is there any classification name, you know?
Yes, ma'am. There is the Uyama and Asayama classification.
Yeah.
They had
So
described.
this is you will see the all hypertensive retinopathy related changes. The
Yes, ma'am.
same thing like in coarctation. What are the changes you will see in fundus?
Ma'am, in coarctation, we will see a corkscrew type of vasculature. We will see U-shaped bends in the arteries. However, we will not see the hypertensive changes. That is
Why?
uncommon.
Why?
Uh,
This is also hypertension.
yes, ma'am.
And here, why there is no hypertensive retinopathy in coact and in aortoarthritis you will see. What is the reason? Have you ever thought?
Mainly because of continuous pressures.
No, from where the ophthalmic artery is taking origin.
Mhm.
Ma'am, from the intracranial, like internal carotid. And the cerebral autoregulation that is there.
Because coarctation is a congenital disorder. It is intrauterine life. It has been started, and the baroreceptors they are already set at the higher pressure. That's why they are protecting the retina vessels for any hypertensive changes. Whereas in aortoarthritis, it's an acquired disease. Okay, go ahead. But please don't forget to mention that fundoscopy in a patient if you get a long case of aortoarthritis. Okay,
Is there any
go.
reason why you could not see it?
I'm actually, we do not have a fundus, like a fundoscope at hand, ma'am.
Usually students used to carry the fundoscope. It was not
Yeah.
allowed in the hospital. Okay. And another thing is to classify the severity also, capillary filling time is one thing. Actually, to say that arterial disease or venous disease. So it is worth mentioning in all these arterial disease also, even though it is, we know that it is a large vessel involvement and not the, not the small vessel involvement, but it's maybe important in a few of the cases. Okay, go ahead.
So my final diagnosis, a clinical diagnosis, is a 20-year-old female with Takayasu aortoarthritis involving bilateral carotid arteries and abdominal aorta with uncontrolled hypertension.
That's what previously also we talked about. You say it's abdominal aorta. You have the on the paraspinal region and
Correct.
almost in between the scapula you have it. And
Where
when
did you mention? You didn't mention Amrita. You said just paraspinal, but you didn't say where exactly paraspinal.
Ma'am, on the left, yes, ma'am. Ma'am, it was present over the entire thoracic region, ma'am.
So, but you heard it in thoracic region, then why are you saying abdominal aorta?
Ma'am, actually, over the abdominal aorta, also the bruit was well heard. Ma'am, over the
But if
entire
you,
descending aorta, ma'am, this should have been thoracic and abdominal aortic involvement.
but
so
once
if
the
you,
proximal
You
obstruction is there, you can't be very certain that whether it is a bruise, a separate origin or not, unless the severity is differs in that way. So, but for your certain is the thoracic involvement. Abdominal involvement is doubtful.
the only thing she said, prominent abdominal epigastric pulsations corresponding to aorta.
Yes, ma'am.
Yeah.
So that part should be above the obstruction. If you are feeling a strong aortic pulsations, it cannot be in the low pressure area. It has to be in the high pressure area.
so you know what is madam is talking about who coined the term middle aortic syndrome?
Dr. Sen and Sharma had coined the term middle
Sen
aortic.
and
Dr. Sen and Dr. Sharma.
not Sharma, Dr. Kinare, Suman Kinare madam. She's from where?
KM.
Yeah, she's a cardiopathologist, world-renowned cardiopathologist, Madam Suman Kinare, and she had coined the term middle aortic syndrome. The thoracic aorta, what Madam is saying, abdominal aorta pulsations are palpable. It must be beyond. And with this, your diagnosis, how you justify it is a aortoarthritis? You said carotid arteries involvement.
Yes,
Will
ma'am.
it justify your aortoarthritis diagnosis according to the criteria?
Ma'am, it won't go against the involvement if we have an arch vessel involvement as
What
well.
is mandatory? Subclavian. It
yes,
is, you didn't mention.
Yes, ma'am. Ma'am, the upper limb pulsations and blood
Then
pressure.
your diagnosis is not correct.
Ma'am, if we consider,
Did you auscultate for the subclavian bruit?
yes, ma'am, there was no bruit present over the subclavian arteries.
So then it is one of the major.
Yes, ma'am.
And
And you have
and with
hypertension
this,
in both upper limbs, so there is no subclavian artery involvement. 190 by 110.
okay, and with this, okay, what are the points which are missing in your diagnosis? You said about the artery involvement. You said about the uncontrolled hypertension. Anything else? I'm expecting you to
I would like,
mention.
ma'am, I would like to discuss the disease activity as well. But
No,
ma'am,
no, no. Your your diagnosis is incomplete. You are supposed to mention the LV function. You are supposed to mention the sinus rhythm. You are supposed to mention any embolic phenomena or arthritis sort of any disease activity if there is a constitutional symptoms.
ma'am, for
And
disease,
LV function, why it is important in aortoarthritis? Are there any myocardial involvement?
yes, ma'am, there may be myocarditis and LV.
Which age group and which series you are talking about?
Ma'am,
Have you read the literature?
yes, ma'am. Ma'am, recently there was a,
Not recently, our Indian authors and the contribution.
ma'am, there was a series by Dr. George Joseph which has mentioned myocarditis. Ma'am, then
Which age group?
age group, I'm not sure, ma'am.
Then you had not read it. And you aortoarthritis, there is a, cooing murmur, okay, of a aortic flow murmur or a aortic valve involvement. But you had not mentioned about the sinus rhythm, NYHA class, or anything, claudications type under
Ma'am,
diagnosis. Yeah, you are supposed to complete the diagnosis.
ma'am, the,
Okay, okay.
So
How
you
will you
want to
proceed?
reframe the clinical diagnosis with the additional features told by Dr. Hetan.
Hmm.
20-year-old female with Takayasu's aortoarthritis involving bilateral carotid arteries and descending aorta with uncontrolled hypertension
Rather than you would have said the involving the arch vessels, then it is fine. Okay.
in normal
Yeah.
sinus with NYHA class 1 with no evidence of LV dysfunction.
In with good LV function.
Yes,
Okay.
with good LV function.
And no pH.
Yes, ma'am.
Why? Pulmonary artery involvement is there or not?
Ma'am, in her case, there
In
is no.
aortoarthritis, which series and the book you had read for aortoarthritis?
Yeah, previously we discussed about that. Pulmonary
Okay.
artery,
Oh, sorry,
carotid
sorry.
artery,
So
coronary
pH,
artery
why
involvement.
I should mention?
Ma'am, in the George Joseph Sir's article spanning from
No,
96.
no. Who had coined the? There are various types of aortoarthritis. The lung vessels, the pulmonary artery also gets involved.
Yes,
So who
ma'am.
had coined that? In which year? That pulmonary involvement in aortoarthritis. You know or you don't know?
Yes, ma'am. No, ma'am.
And coronary artery?
Ma'am, there may be a 20, roughly 10 to 30% coronary artery involvement, ma'am, but when it was coined,
No. You had not read the literature. Who had whose contribution that coronary artery involvement in
Coronary
aortoarthritis?
artery, there is a study by Dr. Sen, around 102 patients from
Doctor?
Dr. PK Sen's study from India. Around 102 patients
No.
that
Our
displayed of
Dr.
cardiac involvement.
Manutosh Panja sir had coined the coronary artery involvement in
Artery
aortoarthritis.
from
You should read the book of tropical disease in India and the Manutosh Panja book only on aortoarthritis. Otherwise, your presentation is not complete. And how many percentage involvement, which artery most common involvement, and that you should be aware of. Okay. Sain Kinare involvement is only a
Only
middle
20.
aortic syndrome. Okay.
So
Go
what is
ahead.
the investigation you wanted to do it?
Yeah.
Ma'am, first I would look for acute phase reactants, ESR and CRP. This will help tell us whether the patient is in active phase or not. We would also want to undergo a CT aortogram. This will give us an idea of
But apart from, sorry, I'm interrupting you again. Apart from today's, we are in the era of non-invasive imaging. Like, oh, your only lab diagnosis is enough to rule out disease activity?
no, ma'am. Ideally, we would be able to do a PET CT scan. This will give us
Obviously, you have to do the PET. It is
yes,
mandatory to know the disease activity.
yes, ma'am.
And
that,
then CT autogram.
ma'am, I would
Okay. Okay, proceed.
Ma'am, I would also want to look at an echo to look for the presence of any aortic regurgitation or LV function, and CT
Yeah, echo is the component of the investigation, but clinically you are not expecting anything. So I would have been more happy if you have said that secondary hypertensive changes to see for it. Clinically, you are not seeing any one of them. If you have a trivial AR, also it is not going to be an effect. So aortic root size and the hypertensive changes to be the same. Then
Yes. So CT aortogram to look for the aortic root sizes and for the involvement and for thickening of the aortic vessels and the stenosis. PET CT to look for the active foci in the vessels.
What are the features on CT autogram you are expecting in a patient with aortoarteritis? Are you expecting a root dilatation? Are
Ma'am,
you expecting then?
Ma'am, a root dilatation may be present. In the active phase, we will see thickening of the vessel wall. We may also look
What
for a
is tree bark sign?
tree bark will basically refer to the the tree bark-like appearance of the intima. This is typically described on the biopsy specimen, ma'am.
I'm on CT, 3 bar will be a wrinkled or roughened intimal appearance on CT.
And you would like to, important thing is here uncontrolled hypertension. You would like to see the renal artery involvement on CT autogram
Yes, ma'am.
or any abdominal aorta. You are clinical, you find there is a middle aorta being having a lesion. Okay. Now my questions to you. How will you see your echo? There are no features of LV dysfunction. LV is fine. There is no feature suggestive of disease activity. We had performed the CT autogram. You find there is a renal artery osteas are involved and there is a middle thoracic aorta is more than 70% lesion. How will you manage?
Ma'am, since the blood pressure is not being controlled on medication, we may consider an endovascular intervention.
What
Typically,
endovascular intervention?
ma'am, a balloon angioplasty is usually what we can do as a first resort.
Whose contribution maximum in India about the interventions in aortoarthritis? Which series?
Mainly Dr. George Joseph's series and Dr. Danda's
No,
series.
your stock is only South, but there are other contributors too.
And the series from GB
Dr.
10.
Raj series is also.
And plain balloon angioplasty will open
Sunday
the lesion. Any specific balloon you will plan for the intervention?
Yes, ma'am. Ma'am, we can also consider a cutting balloon because the
Why
lesion,
cutting balloon?
ma'am, because the arterial vessels are usually stiff and they are difficult to dilate with a simple balloon. So a cutting balloon.
Aortoarthritis is a disease of what? Intima,
Ostia.
media, or adventitia?
Ma'am, it is a panarteritis. We will typically have a lot of
But
fibrotic.
majority involved
Mainly
what?
adventitia.
Ma'am, adventitious
Media.
fibers are the main change, ma'am.
And you have to cut that layer, and that's why cutting balloon is mandatory in a aortoarthritis lesion preparation. Will you put a stent?
In the face of any dissection that may happen or any perforation, in that case, we can consider a stent uh, as an as an adjunctive stenting strategy.
If patient develop a left main ostia critical lesion, Okay. What advice you will give?
Ma'am, in case of coronary artery involvement, a bypass surgery is usually a better option because there is a high chance of restenosis after
What
endovascular.
specific advice you will give to the surgeon?
Ma'am, first we will have to look for the internal mammary arteries, whether it is patent or whether it is involved in the.
Here, subclavians are always involved.
Yes,
Will
ma'am.
you ask them to perform a arterial graft or venous graft?
A venous graft would be preferable. However,
Which other condition in cardiology you advise surgeon to do? Go ahead with the venous graft. You know or you don't know?
no.
I think we'll go to the
Okay.
presentation.
Okay. Now anything else?
You have any
Please
investigation you want
present.
to show for this patient?
Yeah, any CT angio or anything is available?
Yes, ma'am. I'll share
Have to
my.
have a separate
We have
presentation.
to stop sharing this. PPT.
Amrita, stop sharing
Take
so
it.
that you can share.
There was some LV diastolic dysfunction with E bar E prime of 15. The arch vessels, ma'am, the first vessel which is coming is having a bend which is in a U shape with a gradient of 23 at the right, the brachiocephalic trunk. I can't see the color flow in the other two vessels. In the left common carotid flow, I cannot make out from the arch. In the abdominal aorta, I can see a continuous gradient, ma'am.
So before you
Continuous.
comment on the flow, what would you like to comment, Kunal, on the
Ma'am, the vessel walls
caliber
are
and
thickened.
the vessel wall? Yeah.
Yeah, vessel walls are thickened and the lumen looks smaller.
Lumen looks irregular. I think
Yeah, irregular.
one clue you should always look for when you image the aorta is look for irregularity of the aorta, okay? Which you will not see in a coarctation.
Yeah. Okay. Then there is diastolic tailing also and abdominal aortic gradient of around 25. This is the celiac and the superior mesenteric vessels with low turbulence at their origin. Gradient of almost 40 to 48 maximum at the origin of the celiac vessels. This is in short axis the abdominal aorta, then the origin of the celiac vessels. Left
Go
subclavian.
back to the previous slide. Go back to the previous slide. You're not only showing this thing, can you see you're showing the renal
The
artery
renal
also, right?
arteries
Renal
also, ma'am.
artery. You're showing
Both the
SMA
renal
and right renal,
and both the renal arteries.
there is a good turbulence across the right renal artery.
Yes, ma'am. But
And
ma'am, the origin, the connection of that flow from the aorta is not visible here, ma'am.
it looks really small. Yeah.
Yes. Subclavian, ma'am, we thought there is some increased flow or flow turbulence, but the gradient we got was only 6. So I'm not shown that. In the right common carotid, I was trying to see if I could see a macaroni sign, but I was not able to see, and there was no flow turbulence there. On the CT aortogram, you can see there is different branching pattern. This is like a pseudo bovine branching pattern with a tortuous right common carotid. On echo, this is where we had got a gradient of 25. The left common carotid is occluded totally here and cannot be traced in the neck. The occlusion starts from around between the descending thoracic aorta itself and throughout the abdominal aorta is narrower, extending into the both iliac arteries, with left iliac artery up to almost up where it is entering into the pelvis. Till there it is narrow. Otherwise, below it is okay. The renal arteries, if I will try to zoom, the right renal artery here is totally occluded. Left renal artery has around 80 to 90% stenosis. And the right renal artery is getting some collateral flow from some celiac vessels. Apart from that, in this reconstruction, we can also see is the chest wall vessels which are forming some collaterals, and they're going right up to the superior epigastric and the inferior epigastric forming collaterals and going into the femoral artery.
And right kidney appears smaller.
Yes, ma'am. Right kidney appears smaller. On UAG, ma'am, right kidney size was 8 and left kidney size was 9.5. This is the celiac artery origin. Here, ma'am, the right renal is almost cut off at the origin.
Yeah, right
And there
renal
are
is
some collateral.
completely cut off. Yeah, I agree.
Yes, ma'am. And some collaterals are coming and they're draining into the distal part of the right renal artery. And the left renal artery is also involved. We can see both the vessel thickening and the ostial narrowing there. Another thing to note here is we can see in the anterior abdominal wall, there are prominent collateral channels formed here.
And can you appreciate the vessel wall thickening of the aorta?
Yes, ma'am.
So thick it is.
Here, ma'am.
Yeah.
Almost like a double ring, ma'am. There.
Hmm.
There is an inner dark ring and an outer bright ring. And this is the collaterals, the Winslow's collaterals draining into the femoral artery. And this is the thick wall of the ascending aorta. Here I would like to show the carotid ones. This is how it is branching from single origin. There is some kink here, but this vessel wall is not thickened. Consistent with our USG finding also, we didn't see any vessel wall thickening. Here, left common carotid is totally occluded. Then I have few steels where I'm showing the thickening of the descending thoracic artery, and also we can see the size difference between the ascending and descending. Here, right carotid is seen, but left carotid, there is no contrast uptake at all. There is some calcification in the arch. There is thickening with double ring sign. Again, this same I have shown already. Celiac and the superior mesenteric. And then that's all in the imaging. Interestingly, ma'am, this patient was evaluated extensively for CSOM at some other medical college and tertiary hospital, where they had evaluated for resistant hypertension. So they had done an extensive workup for hypertension, including creatinine of 0.7, potassium of 4.2, and urine routine, urine protein creatinine ratio, TSH, lipid profile was normal. And they had also done a panel to see for other secondary causes of hypertension. So serum renin was more than 500, while serum aldosterone level was normal. Plasma methanephrin were normal. Again, ANA blot, ANCA panel was done, which was negative, and serum C3 and C4 were normal. Fundoscopy revealed a grade 2 hypertensive retinopathy.
What's the take-home message from all these investigations, Kunal?
Ma'am, the take-home message is all this could have been avoided if simple clinical examination and a four-limb BP was measured, or even
Exactly.
a proper clinical examination would have been done.
Even palpation of pulses would have given the
Yes, ma'am.
diagnosis. An absent low limb pulses would have given the straight diagnosis of aortic occlusion.
Yes, ma'am. It was only when the patient went for pre-operative medical fitness for the CSOM that the patient was diagnosed to have hypertension.
Yeah,
What
it's
is
a
the
really
management?
nice case and a nice presentation by the discussant
Final
also.
word about the management?
Almost she discussed each and every component very well, and Hethan
Yes.
included the literature very well, I think. We can conclude now here and we can go for the presentation.
Okay.
What
Sujata?
will be the management outlook, ma'am, for me?
Yeah, management for this patient.
ESR is 8, CRP is only 1.1. But ma'am, there is signs of disease activity on imaging, like the double ring sign, the intimal edema.
Yeah,
With
PET
rheumatoid
scan should have
leukemia,
been done.
ma'am. Next investigation is PET scan. And the patient is planned for a coronary angiogram and a pulmonary angiogram, ma'am, in the next week.
Any other medical tests would you like to do to look for activity? Not all
Interleukin
patients
6
will be
would be
able
of
to
value
offer
in
PET
this patient.
scan. Sorry? Yeah,
Interleukin
correct.
6 in this patient would be of value.
Yeah, very good. So IL-6 makes a lot of difference in assessing disease activity because ESR and CRP are negative even in many patients with disease activity. And even an MRI can show disease activity. So why do you want to look for disease activity?
And the results of intervention will be poor in presence of disease activity.
Rather than
Okay.
poor
To
outcomes, it's
We would like
complications.
to, yes, ma'am.
we would prefer doing an immunosuppression, and then once the patient is not an active disease, then it would be more prudent to intervene.
What
And
immunosuppression? If patient has a disease activity, ESR, CRP being raised, what would be your management?
first we would start with
Direct
steroids.
immunosuppression?
No, sorry.
Directly immunosuppressions or anything else?
We can start with
Antihypertensive.
hyposteroids along with synthetic DMARDs. So a combination will help us to taper off the glucocorticoids earlier.
Okay. And if you are given, but still the disease activity is not under control, ESR is persistently 100 beyond, then what should be your plan B?
In that case, we can change to a different we can change to a different DMARD, or we can change to a biological DMARD. We can use either tocilizumab or any TNF alpha inhibitors.
Okay. What the literature shows, is there any role of empirical AKT in such case?
Yes, ma'am. I would like to roll out TB system.
Yeah,
Uh,
tuberculosis. What Madam Kinare had mentioned in India, we should not. I had one patient. She was surviving only on one vertebral artery, and her ESR was persistently 110, even though on immunosuppressions and all. So I had to give empirical AKT, and with 3 months, her disease activity got controlled. So in India, there is a role of AKT in such case if all activity has shows no result. Okay, good. And intervention in this case?
Once the disease activity is controlled, we can reassess. If the hypertension is not controlled, for uncontrolled hypertension, we may consider.
Now you know the lesion morphology. Renals are involved, carotids are involved. There is a mismatch between the ascending and descending aortic gradient. You are planning for pulmonary angio, right?
Yes, pulmonary and
That
coronary angio is.
specific test you will like to do if you are taken, you will do invasive pulmonary angio or CTPA.
Ma'am, CTPA would suffice, but if you're doing an invasive coronary angiogram,
So ideally, at the time of aortogram, you could tell the radiologist to screen for the pulmonary.
CTPA. Yes,
But
ma'am.
here, if you are taken patient on table, what things you will like to do before intervention?
Ma'am, we can test the gradient across the descending aorta.
Pullback gradient,
Invasive.
pullback,
Yes, ma'am.
because
Pullback.
there is no as such focal narrowing nahi hai. It is a tapering of the vessels. So
Yes,
if you plan for any interventions, and what intervention will help her for controlling the blood pressure in her case?
Ma'am, the renal artery stenosis should be opened. So renal artery stenting will help her control the blood pressure.
But
But
here the left renal is completely cut off.
yes,
Will you try to probe it?
ma'am, if it can be
No,
opened,
ma'am.
it will help decrease the renal
Here
levels. However,
it is like it, no? It is completely totally cut off. So what would be the management for left?
ma'am, if the hypertension is not controlled by other methods, a left nephrectomy may be
Nephrectomy
considered in her case.
after doing the DTPA scan.
After
Or is there any role of auto-renal transplant? What is that term? The surgeon, like other vessels, other organ, they take a graft from the iliac or beyond, and they put a graft from aorta to the renal transplant, renal artery transplant.
Renal
Our
autograft.
urologists do at KM.
You
If
can put
you
a jump
can't see,
graft.
yeah, jump graft, yeah.
Yeah.
I think we'll go to Dr. Usha's present.
Yeah, PV and
Thank you, Amrita and Kunal. You've done a great job.
very good presentation. Yeah.
Yeah, we should appreciate Amrita almost answered each and every question, and she read it so well, and it's very nice.
Thank you, ma'am.
Good evening, everyone. I'll just make a quick presentation. I'll not take more than 5 to 10 minutes. Current concepts and management in aortoarthritis. Aortoarthritis is a large vessel vasculitis of aorta and its branches. And giant cell arteritis and aortoarthritis are the two large vessel vasculitis described. Highly prevalent in the Asia and affects females more than males. No clear pathogenesis. And 1/5 have a monophasic self-limiting course, so they form a very small percentage. Most of them, the disease is for lifelong. It is continuous, relapsing, and remitting course. To describe aortoarthritis in a nutshell, it's a chronic disease for life with various theories of etiology, with recurrent exacerbations, and actually there is very little evidence on management. So these are, I think the case which we had illustrated very clearly how badly the aorta can be involved. These are various patients of different ages. I am basically a pediatric cardiologist, so all these images you're seeing are from children who had extreme involvements of aorta, and the disease never seems to remit or never seems to give them at least even few months of peaceful life. There are various theories on pathogenesis. Th1 and Th17 immune-mediated responses, an imbalance between Th17 and regulatory T cells. There are some cells called dendritic cells. They are supposed to be the gatekeepers near the vasa vasorum, and they get activated abnormally. So once these dendritic cells are activated abnormally, they allow all the cytokines and these other active inflammatory cells to enter the vasa vasorum. So like Amrita mentioned, the inflammation starts near the vasa vasorum and spreads to the entire vessel wall. Aortoarthritis is a pan-arthritis, is starting from vasovasorum and ultimately involves the media and adventitia. So all the stages of aortoarthritis clinically comes as a early systemic or a stage where it has a lot of constitutional symptoms, and it is a prevasculitic stage. Very few patients present in this prevasculitic stage. A second stage is the vascular inflammatory state where you have vascular pain, stenosis, and aneurysms of the vessels. So this is the carotidynia. Then you get a burnt out state or a fibrotic state where you have frequent remission and relapses. And most of the patients come in this fibrotic stage because either there is a renal artery involvement and renovascular hypertension, or the aortic involvement as in the patient we just discussed. And the most common presentation is hypertension. And usually the presentation happens in the third stage. And progression, once it goes through the vascular inflammatory state, the progression can be persistent. Clinical diagnosis, most of the time diagnosis is by imaging. Constitutional symptoms, like in our patients, rarely arthralgia, synovitis can happen. 25% of the patients can come with carotidynia. Claudication and syncope due to hypertension are other manifestations. Majority of patients, even including our series at Jaideva, uncontrolled hypertension is the manifestations. And the next subset of patients come in shock or dilated cardiomyopathy or initially diagnosed as myocarditis. And once you have a patient of any age group with a diagnosis of dilated cardiomyopathy, never ever miss the diagnosis. Always make it mandatory to palpate all pulses. So it's not just right upper limb and right lower limb. Make sure that you palpate all pulses, both brachials, both radials, lower limb pulses, and do palpate carotids because sometimes you may get a thrill or a bruit without involvement of other arteries. So heart failure, look for aortoarthritis. Uncontrolled hypertension, look for aortoarthritis because DCM is a kind of idiopathic dustbin diagnosis where you cannot do anything much, whereas aortoarthritis, at least you can offer some interventional treatment. Palpitation, shortness of breath, chest pain. Rarely annuloaortic ectasia happens leading to AR and root dilatation. Sometimes we have had patients come with the diagnosis of rheumatic heart disease due to aortic regurgitation, and mitral regurgitation actually turned out having aortoarthritis. So if you have valvulitis, if you have hypertension, if you have heart failure, then you think of aortoarthritis. Myocarditis and myocardial infarction rarely can also be a manifestation due to coronary ostial narrowing. We have had some patients come with GI symptoms due to celiac artery involvement. Pulmonary artery hypertension, we already discussed, can also happen in aortoarthritis due to stenosis of the branch pulmonary arteries. So again, manifestation can happen either due to stenosis or due to aneurysm. You can have severe narrowing leading to severe PAH. You can have large aneurysms which breach and lead to life-threatening hemoptysis. So we have seen both kinds of patients presenting with a diagnosis of aortoarthritis. It can mimic various other differential diagnoses. So clinically, look for asymmetric pulses. Hypertension, as I said, is the most common clinical features. You get bruise. Make sure you palpate all pulses in all patients with heart failure. What is little different in children? Though literature says 8 to 13 years of age, we in our center have seen children as young as 1.5 years presenting with large vessel vasculitis. And in one of the conferences, I think from Chandigarh, they reported a child who was around 5 to 6 months old who had large vessel vasculitis. Compared to adults, males are also significantly affected in children, and the manifestations are more severe and often unsuspected, and presentation is late. Ma'am was just discussing all different branches can be involved. There are various series with regard to involvement of different branches of aorta. Coronary artery involvement can vary from 7% to almost 40% in one of the series mentioned. So how do you diagnose? We had a discussion during case presentation on the imaging modality to choose. Conventional angiogram initially was mentioned as gold standard, but we always try to use CT angiogram as the initial modality of imaging, because the amount of dye, total amount of dye that is required is less. You can look at all the vessels and you can look at the distal branches also. CT iodogram not only demonstrates the inner vessel wall lumen, it also demonstrates the thickening of the vessel wall, which you will definitely not see when you do a conventional angiogram. Of course, radiation is the risk either with conventional or with CT, but nowadays the protocols with the current CT, the radiation risk has come down significantly. Compared to all modalities of investigation, whether it is a conventional CT, MRI, or PET, if you want clear delineation of small arteries, especially we are worried about renal arteries in patients with aortoarthritis, CT is always the best bet. PET CT or MRI may show activity, but they can never give you a clear or a crisp image of renal artery involvement. MRI again will show, if you are very keen on looking for activity, wall edema and thickness can be demonstrated by MRI. MRI is a good modality for follow-up rather than initial investigation of choice. If you want to investigate, if you want to diagnose, and if you want to look for the significance of the lesion and quantify the lesion, CT is always better than MRI. Like Dr. Hetan mentioned, PET CT gives a good idea of disease activity. Sometimes you have patients coming in heart failure even on high levels of immunosuppression, and you're not sure whether you have to scale up or add new medications, and you're in doubt, then you can go ahead and do a PET CT to look for activity. So the recent addition to this is a Doppler ultrasound, where they have measured the thickness of the artery as a sign, which Kunal was mentioning already, as a sign of aorta arthritis. But again, this is highly operator dependent. So unless the operator has experience in looking for this, it may not be very sensitive. But this is something you can try looking for when you think of aorta arthritis as your diagnosis. And as I mentioned in echo, look for irregularity of the aorta. That is a more specific sign of aortoarthritis. So we always do CT angiogram, conventional angiogram only when you are thinking of a intervention. So there are various classifications based on the, you can look up this. I don't have to go into the details. Initially, though there are different classes, actually this doesn't, this is of mainly epidemiological significance. And once you follow patients for a long time, you realize that it is just a different timeline in the disease course. Once they have a disease for many years, most of them finally end up with whole of the aorta being involved. So this classification is actually kind of redundant, except for epidemiological significance. So this was the numerous classification, and A is coronary involvement and B is coronary to PA fistula, and you add a pulmonary artery involvement also. So how do you monitor disease activity? This is a $1 million question in aortoarteritis. There is no specific answer. Elevated CRP and ESR conventionally have been used for indicators of active disease, but more than 30 to 40% of active patients can have normal ESR. And if you have any intercurrent infection, of course, you can have elevated inflammatory markers. So the new novel markers are matrix metalloproteinases, IL-6, IL-18, IL-8, IL-1, and pentraxin 3. Right now, among all this, what is available is IL-6 because of the COVID pandemic. And IL-6 seems to have a significant role in inflammation and aortoarteritis. So because imaging cannot be done bedside, various criteria has come over last 4 to 5 decades. Ishikawa criteria, you can all go through it. And sensitivity and specificity in Indians has been around 60 to 95%. And as like Dr. Hetan ma'am mentioned, involvement of subclavian artery has been the focus in all this. But if you take this criteria, there can be a subset of patients where you can miss the diagnosis of aortoarteritis. There is an American College of Rheumatology criteria, and there is the latest Dr. Sharma's criteria also, which is actually has the highest sensitivity and specificity. In the pediatric population, there's a EULAR or that is European League Against Rheumatology criteria. Actually, this is one of the most sensible and logical criteria where the chances of mislabeling a patient is less because a presence of an angiographic abnormality, either by CT or MRI, is a mandatory criteria. And if you have any additional one criteria, like hypertension or an absent pulse, then the patient automatically gets diagnosed as Takayasu arteritis. Because if you use major criteria as subclavian, like in this patient, subclavian artery involvement was not there. So you cannot rule out aortoarteritis. EULAR criteria is one criteria where your chance of misdiagnosis is less. And of course, like you have a lab criteria for inflammatory markers, there is one PDF sheet we use for all our patients and try to compare. This is the Indian Takayasu Activity Score by Mishra et al. Gives a good correlation when you, which also has included ESR and CRP, gives a good idea, especially when you're following up a patient and trying to alter the treatment. So what are the main headings under which you will give treatment? It would be immunosuppression, supportive therapy, and interventional therapy. Immunosuppression, traditionally glucocorticoids has been the mainstay of treatment. Other immunosuppressants, as Amrita mentioned, the conventional immunosuppressants are methotrexate, cyclophosphamide, and azathioprine, among which methotrexate is commonly used. Cyclophosphamide you use if it is a highly resistant disease. Azathioprine is one of the milder immunosuppressants. Mycophenolate mofetil has come into existence in the last few years and is a good immunosuppressant and which we routinely use in our institute. And of course, the biological agents, the major hurdle in using a biological agent is the cost. Among them, the most commonly studied biological agent is IL-6 inhibitor tocilizumab. TNF alpha blockers, etanercept and infliximab also have been studied, and Janus kinase inhibitors also have been found to have some benefit. The disadvantage is there are no randomized trials, there are no specific guidelines. The largest study with tocilizumab was with 36 patients and 42 patients. I'll just come to that. So this is the guidelines, both EULAR and ACR guidelines I have put. So what do you do when you diagnose Takayasu arthritis and patient is in activity? So you use high dose glucocorticoids. We tend to use IV methylpred when we see a high level of activity. And actually, there is a recommendation to add other non-glucocorticoid immunosuppressive agent along with your glucocorticoids. And once you find a remission, you taper the oral glucocorticoids and you continue the non-glucocorticoid immunosuppressive. So if you have a if there is no relapse, you just consider only non-glucocorticoids immunosuppressant. If there is a relapse, you can increase the glucocorticoids, and if it is not responding, you can consider biologicals. So all this is easy to write in flowcharts and tables, but very challenging to manage clinically because many patients achieve remission only when the glucocorticoids are high, and within 2-3 months of tapering, they go back into activity. So how do you manage lesions? So if you have vascular changes identified, look for inflammation, you give immunosuppression. Once there is quiescence of activity, then, and if patient is asymptomatic, just continue monitoring. If there is evidence of ischemia, you should consider angioplasty or surgical treatment. So if disease is quiet for more than a year, steroids can be tapered and stopped. So tocilizumab has shown evidence. Once tocilizumab was started, there was suppression of clinical symptoms. There was improvement in angiographic findings, including case reports of resolution of coronary stenosis. And it has steroid-sparing effects in almost 65%. But they found that as soon as tocilizumab was stopped, relapse occurred in almost 50% of these patients. So others also have been tried, but no superior effect compared to steroids. Steroids itself has a whole list of side effects which you should be aware of before you give steroids on long-term duration. Do not forget antihypertensive. Do not forget calcium and vitamin D supplementation when you're putting the patient on long-duration steroids. And remember that aortic arthritis is a hypercoagulable state. We have had patients coming with Buchieri syndrome. We have had patients coming with thrombosis of the entire aorta. I don't know if you remember one of my first slides which I showed. The whole aorta was thrombosed. So anticoagulation may be required, aspirin may be required in all these patients. Intervention is required when vascular complications arise, when there is uncontrolled hypertension, or if there is severe AR or root dilatation, or if there is a critical coronary artery disease. Interventions best done during quiescence, otherwise you can end up with life-threatening dissection of these arteries. And the risk will be almost impossible to manage. So what is the take-home message for intervention? Always avoid stent whenever possible because ISR is extremely high because there are recurrent activity exacerbations which happen, and once you have a stent in place, there is severe intimal hyperplasia and in no time the stent can close. That's why one of the series by Dr. George Joseph, they have used covered stent to reduce the incidence of ISR, especially for renal angioplasty. And always balloon is preferred rather than stent placement unless you end up with a flow limiting dissection. So in Jaideva, we have almost around 150 children who are under follow-up between 1 to 18 years of age. Again, as I said, male is to female ratio is not significantly different. Every part of the aortic branch, we have found involvement. They present most of the time as acute heart failure and shock, hypertensive crisis with strokes, with seizures, encephalopathy, venous thrombosis. Recurrence rate is extremely high. The disease is unforgiving in children. We have used whatever possible agents are mentioned in literature, and we keep switching from one agent to the other because there is no significant control. We work with our pediatric rheumatologist, but again, our mainstay of treatment is glucocorticoids and MMF, and rarely, when not controlled, we have switched over to IV cyclophosphamide. For discrete lesions, again, putting a stent is almost impossible because there's no growth potential for stents. Balloon angioplasty is always the options. Rarely we have sent children for renal angioplasty or jump grafts, as we just discussed. Operating a child and inserting a graft, a child will outgrow the need. Again, that can be a problem. But if there is no other option, you will have to go for it. And balloon angioplasty is always better than stenting. Thank you.
That was an excellent summation, Usha. Literally,
Thank you.
anybody has any questions?
Yeah, actually, I want to request Usha to submit this experience of Jayadeva to our IJCD.
Yes, ma'am. Yes. We are compiling all our, we have a follow-up of almost 5 to 6 years, including all the different immunosuppression and interventions. So we're planning to
Good
send
series.
it for
Excellent
publication.
series.
Excellent. I think this has been so interesting that it has gone over more than 40 minutes over time. So I think if there are no questions, I would like to thank Usha. I would like to thank Jyotsna, Hetan Shah, and of course the Jaydeva PGs who have literally withstood the onslaught of questions from everybody. Thank you, one and all. Thank you, Medgami, for hosting this meeting.
Thank you.